Good afternoon. Well, thank you all for inviting me today. It's really a great privilege to be here, and I'm very grateful for all the support that the Dental Trade Alliance Foundation, as well as all of the different funders that are in this room, have given toward advancing oral health issues. My name is Cheryl Jansen, and I have the great privilege of being the founding chief executive of an organization called Kids Smiles that launched its first dental center in Philadelphia. Today, I'm going to be talking about our Wider Smiles program, but I want to start by saying we've all heard that adage, if you love your job, you will never work a day in your life. I love my job, but that person clearly never worked in a grassroots nonprofit because we work hard. And the challenge that we face on a regular basis is really the number of people that always and continue to need care. And so we have a challenge in front of us. But Henry Ford did get it right when he said, coming together is a beginning, keeping together is progress, and working together is success. And that's what all of you have committed to in this room, and so I thank you. Kids Smiles is a 501c3 that launched with an initiative to provide clinical care in the Philadelphia marketplace with a small education program. That education program has evolved into what we call Wider Smiles, and I'm going to talk more about that as we go through. So as you look at the Wider Smiles program, what you'll see is our vision includes the following. We want to have a positive impact on every patient, expand to other underserved locations. We want to improve patient and family oral health and health literacy education. What I want to stop here for a moment just to say is it really is where the rubber meets the road. We are truly putting oral health literacy in the forefront of everything that we do at this point in our organization. And so what's in front of us is saying, will this make a difference? Can we break the cycle? And hopefully we will. We also want to maximize the efficiencies in our operations. We provide quality of care to everyone, and we create career opportunities for employees in the community. This is a special side mission for me. When we launched our first center, I launched with 4 employees and myself. Today we have over 60 employees in 3 centers, which I'll talk a little bit more about. One of the greatest privileges, and it was like Steve was talking about earlier, you have these things that come in front of you in life. Well, we started this center, and we had a great privilege to start hiring folks from the community. And our board of directors and I agreed that we should support these folks in advancing their careers. So now we have a number, over 24 employees of that 60, that are grassroots members of the community that we have supported to moving on and getting skilled careers. Some of them have stayed administrative, some of them are expanded duties, dental assistants, hygienists, and even one dentist. So it's really quite exciting to have this part as a submission that we have. As we have grown, in addition to our career opportunities, we try to provide all sorts of opportunities for our families. And as we said, our mission is really to provide care and education. Bright Smiles, making sure children are healthy, gives you a bright kid, somebody who's happy, and our education and our Wider Smiles program make for bright futures. The reason that we've been successful is we have an incredibly committed board and staff. I have over 11 of my employees have been there for more than 10 years, and about 25 between 5 and 10 years, so we've been very privileged. The Wider Smiles initiative, which I'm talking about today, is very important because of the trustworthy, informative, and creative community outreach involvement that we have. We serve children 0 to 18. We do preventive and restorative care. We also do some corrective care, and we go into the OR. In the Philadelphia market, we go into the OR 4 days a week, 4 patients per day. In the Philadelphia market, we go into the OR right now 1 day a week, 3 to 4 patients. That was probably one of the most interesting findings to me, the amount of early childhood caries that we're still encountering in our families and across all of the different regions where we work. So we have a lot of work in front of us, all of us, to sort of change that. We were launched in 2000. Our dental centers are in Southwest and West Philadelphia and in Ward 7 in Washington, D.C. One of the great little side parts of it is we are also revitalizing a neighborhood, because those of you who may know those neighborhoods, it's not exactly like their state-of-the-art dental centers that we can walk right into. So we launch centers in those communities. As of today, actually that number's a little dated. We have over 66,000 clinical patients in the 2 markets, and we're providing over 400,000 in free sealants and varnish in addition to all the clinical care we provide. Our Wider Smiles program is the hallmark of our mission. Used to be that the bottom line was the eradication of decay. But today, what we know is that we could keep reducing decay forever and ever and ever, but if we don't change behaviors, we are never going to be able to solve the problem. And so now, our education and our Wider Smiles program is intertwined in our mission equally to the clinical care. And so it's been an exciting opportunity for us. We started with just a few partners. As of today, we have 214 community partners. In Washington, D.C. alone, we have 107 community partners. So we launched our D.C. Center in 2010. That will just tell you the opportunity and the challenge and the need that exists to already have over 107 community partners. What the Wider Smiles program works like is that, first of all, it introduces Kid Smiles to the programs to the community. We go out, we meet with different folks, we meet with grassroots organizations, principals, schools, politicians, just introduce them, oh my gosh, to oral health. People forget that's actually a problem. And then we start to talk about our program. We provide free oral health and health empowerment programs in Head Starts, schools, and our waiting room. We offer free dental screenings with follow-up. We deliver in-school preventive services. We have the in-house Dental Detectives Academy, and we have a Train the Trainer and parent program. Our program was actually created and developed, and the ladies in this picture are by 3 urban teachers. The woman to the far right is our education director, and then 2 other teachers that worked to build our program. It is reviewed by the Pennsylvania Department of Education, and it aligns with the standards in the department. As we've moved along, we started with education programs. We had the centers in our cities, but then what we recognized was there were a number of kids still falling through the cracks, and how were we going to get to them? So we began providing preventive programs in the schools. These are just some, I'm not going to read them all, but just so you can take a look, these are some of our lessons. So it's a lot of fun from the perspective of they go from young children to adults. Of particular fun for everybody, we do them in our weight room and we do them in the classroom, is the Dental Jeopardy. We have also a beach ball game that the kids just love. And this summer, I think I'm working with our team to launch our Summer Smiles program. And so in addition to that beach ball, people will get a beach towel. So it's a lot of fun. How our screenings and prevention work, we still screen any child that we're going to do prevention on. Our first opportunity in schools or Head Starts is we do screenings. The reason we do this is it gives us a real good baseline and understanding what we're going to encounter as far as A, demand for services, and B, the ultimate level of decays that we're going to encounter. Plus, not every family is going to do prevention, so we've touched a life. If they don't participate in the prevention program, they've at least had a cursory exam, and then the way our program works is we call every family. Every family that we touch, one of our assistants or administrator calls back to that family, and we work in reverse. We start with families with the highest incidence of decay, and we work backward. So then we go to another level, and in DC, you can have passive consent for your screenings. In the Philadelphia market, in Pennsylvania, you can't use passive consent. So we do a lot of screenings in the DC market. So then we move into prevention, and our prevention requires active consent by the parents and a health history. And then again, we follow up with every life that we touch. In 2001, when we launched in the Philadelphia market, the schools we regularly visited had 59% decay. We go classroom to classroom and every year, so we don't skip years. So in the timeline that we've been there, the schools we've been in since the beginning, they now have an incidence of decay of 12%. So we're seeing a really nice level of impact. It also helps to have a dental center right in the community because we can work closely with the nurses and they're able to get the kids in for care. We were able to grow the program in DC because of the Dental Trade Alliance Foundation grant, and the Wider Smiles program here is really critical. As you can see in the wards that we are in, the incidence of decay is 36% to 64%. The other wards in Washington are 10 to 30. I only have the baseline information now because we've only been doing this for 2 years. So at the end of this year, we'll have the results to see if there's been any impact in the schools that we're going to. The services rendered are oral health care and overall health education, dental screenings, and preventive care. In the Philadelphia market, we just celebrated that in the last 5 years, we've provided education and services, outreach services to over 200,000 children and families, and in just 2 years in Washington, D.C. to 20,000. So this would not be able to happen if it was not for the Dental Trade Alliance Foundation. And one of the new collaborations that we have is starting in Philadelphia, and we recently received a grant that expands on our Wider Smiles program. In Philadelphia, as you can see, that 16.4% of children had not seen a dentist compared to 8.8% in the suburbs. And in Philadelphia, just so you understand the Philadelphia market, there are about 450,000 public school children. Of the 450,000 public school children, 90% of them are on medical assistance. So the numbers, we grow, our dental practices in the Philadelphia market grow at new patient requests between 1 to 200 children per month. 1 to 200 children per month. In the DC market right now, we have new patient requests of somewhere between 7 and 20 a day. So it's a little bit different market. In wards 7 and 8, there are about 40,000 children that are living in poverty. So at any rate, in the Philadelphia market, that we've just launched a new initiative, and it works with our waiting room education and the dental detective program. This award-winning program, and the curriculum is available on websites, is where we provide an actual education program right in our waiting room and in our new initiative in a primary care waiting room of CHOP. And what this program does is it provides lessons, and when we provide the lessons, a child goes through 3 lessons, and then they graduate. And when they graduate, it is a big deal. They get their picture taken, they get walked around the office, mom or dad gets rewarded. We work to recognize the effort that's happened with these children. 49% of all public school children in inner cities don't graduate, don't finish high school. So now we're teaching that graduation is a very cool thing at a very young age. So in our program, they graduate. The thing that's really interesting, however, is we've been collecting data for the students that have gone through the program. And what we've learned is that 50% of our kids that have gone through the program do better, that we see an improved oral health. But others that have graduated, 50% either stay the same or don't do better. So right now what we're doing is we're analyzing some data that we're collecting to see why. Where are the flaws in the program, or what's sort of the external factors? One thing we know that of that 50%, 80% of those children have asthma. So it's one finding that we already have. I also feel that we're also going to find the rest of them are 12-year-old boys, and they don't do any kind of toothbrushing. So that's the mother of 2 sons and 2 daughters talking. So our newest initiative that we have launched with CHOP, and I'm going to talk a little bit more about that in a minute, is our Age 1 exam program. And we are now giving out this water bottle. And talk about herding cats, I had 15 dentists come together to give me their top 10 list. that we wanted to put on our water bottle. And so we honed it down, and we got our top 5, and we give this to every parent that's coming through with their 1-year-old exams. The Wider Smiles Nuts and Bolts the program runs us about $500,000 a year. We have 6 full-time staff devoted to it and 3 part-time dentists. There's education and training offered classroom to classroom style. The prevention services are exams, x-rays, prophies, and fluoride, but not as many sealants as you would think. We do follow-up calls, and there's screening in our classes. So I'm watching my time tick down, and I first one up in the day. You want to make sure I'm very mindful. So quickly, our new Kid Smiles CHOP Collaborative. CHOP combined CHOP is Children's Hospital of Philadelphia. They combined their primary care centers. It is 56 exam rooms. They average 3,500 patients per month, and we go in and provide on-site lessons, and we work to support referrals to dental offices, and moving forward, we're going to be providing fluoride. This entire collaboration is because of Dental Trade Alliance Foundation. Thank you very much.
Cheryl, thank you. Our next speaker is Dr. Winifred Booker on Lessons in a Lunchbox.
Good afternoon, everyone. As you can hear from Cheryl's presentation, how important education is, and that's the approach that Lessons in a Lunchbox takes. How many of you, there's a handout that's going to be passed out to you because I have so much information to share with you on how much the Dental Trade Alliance Foundation helped us. That first $25,000, we sucked the blood out of it, and you'll see that in this presentation. But if we will also provide you the presentation, if it's okay, online. We won't ship it. How many of you have seen that new Kmart commercial? The new Kmart commercial, it says, ship your pants. I won't ship my pants, but I will email you this presentation because we don't have a lot of time. So without further ado, I'm going to share with you per the charge of this presentation today, the objectives, and I'll share with you first the origin of Lessons in a Lunchbox, again, how the Dental Trade Alliance Foundation helped us, the current status of the program, and the future of Lessons in a Lunchbox. So the idea came from, I was at Walmart to buy a birthday gift for my very privileged nephew, and I always try to buy things that are useful, and anyone who knows me knows that when we give out things, there's multiple uses for it. So as I was shopping for him, I came upon this lunchbox, and it had Spider-Man, and it was in 3D jumping off of it. And I immediately thought, when do you teach a child about brushing their teeth? When is the best opportunity to teach about oral health education? After you've had a meal. When can you do that? When is the biggest audience at school? And so the idea was born for Lessons in a Lunchbox. I'll just go through some of the things. And my dates might be a little bit off because I saw on the brochure where we actually got our grant funding in 2007. So I'll make that correction before I email that too, or put it up on our website. So there was a lot of cutting and pasting done, trying to come up with the name. And finally, we did come up with the names Lessons in a Lunchbox, Healthy Teeth Essentials and Facts About Snacks. This is important to me, sharing this portion of the program with you, or how it was developed. After we did the cut and paste, the manufacturer actually provided us about 4 lunch boxes of how it would look once we got it manufactured. So we decided to do a tour of duty breakfast to educate Maryland or people locally about what we were about to do, what we were about to launch. This is prior to the death of our child, DeMonte Driver. So we had started working on the Lessons in the Lunchbox project back in 2004. So as you can see, we invited local officials, we invited people from the health department, school principals, some of our legislators to this tour of duty breakfast. And what we did in that breakfast is, on the lower left, that's the head anesthesiologist. And what he said to these teachers and the people in this room is, what an impact it makes, how dangerous it is, how expensive it is to put a child to sleep because of early childhood caries. On the lower right, you see pediatrician Dr. Joseph Burke. He's an attending at Johns Hopkins Hospital for the Children's Hospital part, and he talked about how many children he sees from East Baltimore come into the emergency room with dental pain. So these are just some of the pictures of this is a 2-year-old that I had, that this all could have been prevented and avoided. And again, as Cheryl said, it's about education. This is I don't know where the pointer is on here. Is it the top one? It's the side one. This one right here. There we go. Okay. Okay. So, but you saw how small that child was. And as a pediatric dentist myself, I go to the operating room and kids are put under general anesthesia. I've been doing this for 27 years, and fortunately, all the children have gone home. But you know what the anesthesiologist tells the parent? Your child might not go home. And from tooth decay, that's pretty serious. I say my prayers every time a child is put to sleep. So what we did in 2007 is we solidified our commitment. We had this prototype, and we solidified our commitment with organized dentistry. We went to organized dentistry and said, do you support lessons in the lunchbox? Dr. Leslie Grant and I, Dr. Grant, many of you know, who is our Director of Advocacy and Outreach, we took that cut and paste lunchbox and our 4 prototypes everywhere. I'll tell you a story about Henry Schein. So I had engaged Steve Kess, and Steve said, okay, I'll meet with you, and the meeting got canceled, it got canceled again. Well, we were in Chicago at the midwinter meeting, and we were at a breakfast, and I saw Steve Kess go into a coat room. And I went into the coat room behind him and shut the door. And needless to say, he said, I like it. And of course, Henry Schein is one of the groups that have been very supportive of us. And so we continue to write grant and try to identify funding, engage corporations, and in 2008, we got our first shipment. I actually went down to the dock to see the container that our lunchboxes were in. We launched Lessons in the Lunchbox on January 18th, 2008, and in these photographs, you will see members of the Maryland Dental Society, Maryland State Dental Association, Organized Dentistry came together for the launch of that, and we did it in conjunction with Give Kids a Smile that year. 10 days later, we held a press conference down at the National Museum of Dentistry. Drs. Leo Rouse and Dr. Christian Stoller, deans of Howard University and the University of Maryland respectively, attended the meeting. And one of the comments they made, they knew about the cut and paste project because we did a little focus grouping before we did the lessons in the lunchbox to see how realistic it would be to get it done. This is a group photo at the museum. We identified a school that was very diverse. We have a lot of diverse schools in Baltimore, but this school included children that had American Indian background, Hispanic backgrounds, African American, and white. So you can see the diversity there. We have tons of photographs, but this was one, this little boy, one of the last stickers that we were able to get on the lunchbox. It has 7 surfaces, 7 messages, and this one says, see yourself becoming a dentist, or a hygienist, or a technician. In March, we contacted Dr. Jean Sinkford and asked her, could we present to the Council of Dental School Deans? She afforded us that opportunity. And by the end of that meeting, approximately 33 of the deans had said, we want to expose our students to this. They have benevolent project requirements, community service project requirements, and so they afforded us that audience. This is the dean from Missouri getting his lunchbox. So all of the deans got a lunchbox. Can you see that sight, them getting on a plane? Going home with their lunchboxes. After 9 months, we were able to launch the Lessons in the Lunchbox program nationally. The dean from University of Nebraska, Creighton, he continued to contact us and said, we want Lessons in the Lunchbox, so they got it first. And we appreciated their vigilance. So let me count the ways how the Dental Trade Alliance has helped the Children's Oral Health Institute. And I'm going to go through this, as I said, basically what the handout you have covers this in the event. My time starts running really closely. So we got the first, the Dental Trade Alliance Foundation grant funding paid for the first 5,000 lunchboxes and the care case orders. The grant continues to encourage other corporations and organizations to support the program. It has helped us improve the lesson guide. So we didn't just go into the schools and give kids lunchboxes. We do a presentation, one on flossing, one on brushing. They're 5 minutes. But we also gave the teachers a lunchbox, and we gave them a lesson plan. So it started out looking like this. And a company, much like Sylvan Learning Center, called We Teach and Tutor, afforded us these initially. Well, we decided we needed to improve it because teachers were missing some of the signs and symptoms. What the cycle of pain of oral health disease can cause a child in the classroom. Why does a child have their head down on the desk? Is it because they're just not participating? So we were able to improve the lesson plan to a more comprehensive document. These are some of the corporations that have supported us, and we are so grateful. We congratulate all 14 of us that are in this room today, but we particularly thank all of you for allowing or helping us to move forward our nonprofit organizations and the initiatives to improve the oral health of children. So that's what it originally looked like. That's what we still have both of them posted on the website. You can download the lessons, and the lessons are applicable to the grade categories. I'm going to move along quickly because I'm worried about my time. The Dental Trade Alliance continues to make a difference in the dental education of students, and we have 9 things here. Dental students, dental hygiene students learn alternative ways to teach oral health prevention. They continue to be made aware of the tragic circumstances that took the lives of Diamante Driver and Alexander Collender. Alexander Collender died a couple of weeks after Diamante Driver in Mississippi. He dropped dead in front of his classmates on a school bus on the way home. That Alexander Collender and Diamante Driver are stories that dental students at the time when we launched Lessons in a Lunchbox didn't know, so we continue to remind them. And there are other children who have died since. The dental students witnessed the excitement of school children because of the attention that's given to them, and I'm going to share some pictures with you in just a second. The first $25,000 given to us from the Dental Trade Alliance continues to sensitize dental students to the unmet oral health needs of children and adults because of the access to care challenges faced by our profession. They see and hear firsthand accounts of the pain and suffering children experience from untreated tooth decay. Children often want to show them this is what I'm dealing with. Congressman Cummings did a presentation, and he's been out about three times with us, and he talks about, many of you have heard him talk about his own personal experience. And so that he asked the children, raise your hand if you've ever had a toothache. And I told him, say sick tooth if you've ever had sick tooth, because children relate to sick. And you couldn't see the hands of the children who didn't have their hands up. It has encouraged, this money has encouraged dental students to be innovative and think out of the box. They've learned, the exercise offers them a different human perspective of the government medical assistance program, because there's stigmas associated with that, and I'll let you read the rest of it. They're able to obtain student service learning hours toward graduation. They have an opportunity to encourage these children during these Lessons in a Lunchbox programs to consider careers in dentistry. This program, let me move along with some of my slides so you can see some of the pictures. These are some of the schools that have participated in the program. This is Creighton. That's the University of Maryland dental students. That's Creighton, again, giving out the lunch boxes. That's Meharry Medical College. This little boy had just come back to school from having leukemia. You can see his PICC line. mark on his face. They were delighted. These are the students helping to package the lunch boxes. Some of you may recognize when these children died from disease. I'm not going to go through the rest of them. There are many things, but one of the things we're most proud about is the movement, the oral health education movement in Maryland. And in 2012, we were able to get oral health education legislation passed into law. And part of the reason we believe that happened was because of this first $25,000 the Dental Trade Alliance gave us, because it helped fuel that movement. We feel like the lunchbox, because of the visibility of it, you know, it's a three-dimensional object. And you can download the National Governors Association case study. The National Governors Association actually did a case study on how we were able to go about, and we're going to pass out a press release, how we were able to go about getting that done. We hope in the future to be able to encourage or identify other nonprofit organizations in other states to be able to independently do the Lessons in a Lunchbox program on their own. That we have 24 school districts in Maryland, and 15 of them have signed up for Lessons in a Lunchbox. So we're continuing to work on grant funding and hope to be able to continue the program, but it has grown larger than us. We are a very small grassroots nonprofit organization using volunteers, and we just hope that we can continue the program. Thank you again for this opportunity, and look forward to being in touch with all of you.
Linda, thank you very much. And I want to also thank the Alliance. We had seed funding when we got started to begin this program. And there's three parts here. I'm going to start with Forsyth Kids and then share with you what we went on to do. So I'm going to skip this. So I'm trained in evidence-based dentistry and also in dentistry. And I was teaching at Harvard at the time, and Dom DiPaolo invited me to come back to Forsyth and start Forsyth Kids after the Surgeon General's report. And the mandate essentially was make it evidence-based, provide free care to kids, because that's how Forsyth was founded, and don't bankrupt the institution. So we had a little bit of funding to begin with, and it grew. So the hypothesis, essentially, we're a research institute, so we're hypothesis-based, is that an evidence-based in-school comprehensive caries prevention program could achieve healthcare's triple aim. We didn't know about healthcare's triple aim at the time, so this is retrospective history, and we could exceed the 2020 goals prior to 2010. I knew about the 2010 goals, but not the 2020 goals. But at the same time, there's Surgeon General's report, the Healthy People Goals, the Institute of Medicine had come out with their 6 aims, so we wanted to achieve that. We wanted to focus on comprehensive prevention. We looked at some 200 programs in the country, and everybody appeared to be doing incremental prevention, not comprehensive, and we weren't able to identify anybody that had data, so that was another bit. We wanted the best evidence, and obviously we wanted to comply with all the regulations. So this is our fishbone chart. Whoop, I just turned this off. What I want to focus on is the circle on the lower right, the second from the end, where we're doing comprehensive prevention. All those other steps were steps along the way, recruiting dentists, recruiting schools. I'll share one story about recruiting schools. We worked with the Department of Health and wrote letters to 4,000 principals and nurses in Massachusetts, and we got 4 responses of people who wanted to participate. And one of the physicians at one of the biggest school systems said, we don't have an oral health problem in our city. And I said, well, what about the legislative report? And the physician said, I don't believe the legislative report. So there's a lot of learning all the way around. So this was our clinical method. The stuff in white is for what, at that time, what there was evidence for. The stuff in gray is what there wasn't evidence for. Again, I'm trained as a periodontist, not as a caryologist or a pediatric dentist, so I was going on literature. So we provided tooth cleaning and toothbrushes, not because there's evidence, but that's because what people expect. Fluoride toothpaste reduces caries by about 20%. We weren't able to find any data on hygiene instruction altering caries. We delivered care in schools because that's what the CDC recommends. We provided fluoride varnish, 35 to 45% reduction. We used glass ionomer, and we continue to use it. That was controversial at the time, rather than resins, because we were in school and they were saliva tolerant. We also did ITRs, for which there were a lot of randomized trials, but in this country, not well accepted. And we got a lot of flack about what we're doing, which I can share offline. Because we're a research institute, we started with data. We started with Teleform, an SAT-type form, and over the last 10 years, we've migrated to tablets, now iPads and Android pads and cell phones. So I could be in the middle of Africa working on an Android cell phone, collect the data. When I get back to town, wherever that town might be, if there's internet, I can upload it to our data coordinating center. So here's our outcomes. This is the first 6 schools. The y-axis is the percent of kids with untreated decay. The x-axis is the number of visits. So the number of visits were in the fall and the spring, so this over a 6-year period. And each circle represents one school of about 200 kids. So we were able to drive untreated caries in these schools from 67% down to 21%. That top line at 60% is the average for Native Americans, American Indians in this country. The 30% is untreated caries for the population. This is data from the Healthy People Initiative. As was just mentioned, we have acute problems in these kids too. So the y-axis here is percentage of kids with acute infections, pain, swelling, abscess. And the mean in our first visit was 17%, and when we went back 6 months later, a semester later, it was down to 4.5%. Third visit, it was down to 0.5%. So the take-home message here is that we could start with untreated decay at 65% and using comprehensive prevention. We did a lot of work to get these kids into dental offices. Only 10 to 15% got there. So most of the reduction in decay came from prevention. We were able to reduce the acute infection from 15 to 5 to 0.5, and the cost was $68 per patient per visit. That's about 1/4 of what Medicaid currently pays in Massachusetts for dental care. It's evidence-based. It meets the 6 aims of the Institute of Medicine. We did increase access, improved health, and reduce costs. That's triple aim. And we think we reduced overuse, underuse, and misuse of treatment and prevention. We exceeded the goals of Healthy People 2020 prior to 2010. So we took that data, rolled it over, and started Carried Away. This is supported by the Minorities and Health Disparities Institute, and we're in 4 states, Colorado, Kansas, Maine, and New Hampshire. They have programs, and our thought was, let's go to these programs that want to play with us and assess and improve them. So the first thing we wanted to do was electrocute them, get their paper records electronic so we could monitor what's going on. And we wanted to improve the quality of care. So quality is defined by the Institute of Medicine by their 6 aims: overuse, underuse, and misuse. But industry has a different measure of quality, and that's to reduce the variability and waste. So here's one measure of the variability. The states are in the first column, and going across are the number of visits that these state programs have per year. So you can see Colorado does 2, Kansas, Maine, New Hampshire does 1. They see different grades. Maine only seeds grades 2 to 4, and really only treats grade 2. Maine does fluoride rinses and varnish. The other states just do fluoride varnish. Maine seals just the first molars. The other states do different protocols. None of them do ITRs, and they use different materials, and they see about 10,000 students. So that's our population over this 5-year period. Each of these states, we're in a limited number of counties, and each of them, once we get going, can double the number of counties and the number of kids. So this is what we've accomplished so far. We articulated their protocols, and that took us a full 6 months. We found that as we talked to programs and asked, what do you do? They would tell us, we'd write it down, send it back, and then, oh yeah, but we do something else here and something else there. So again, reducing the variability between and within states and programs was an enormous effort. We've moved them from paper records to electronically readable records so we can drop them into a database, and this summer we'll be moving them to Androids. And the other pieces will move them to Glassonimer if they want, and ITRs if they want. And our data coordinating center is managing the data longitudinally so we can give them quarterly reports, not just on process, but also outcome data. And we have contracted with a couple of healthcare economists so we can also do modeling to see whether they can be sustainable, because some of the programs are nonprofits, some are FQHCs, some are run by the states, but all have monetary issues. The last piece, we wanted to work in Hawaii. They have some of the worst healthcare in the country among states, huge Hawaiian population, Native American Hawaiian population. And there, because they don't have a state dental director and they don't have any school-based health at all, it's one of 10 states that doesn't have school-based health, we started at a different place. We started with a social network analysis of the school directors to see who was a thought leader, one, and two, who was for or against oral health as an important issue, and then bring in the prevention program. So this is the same graphic you saw in the other 4 states. They don't do any care. They have about 125,000 Title I kids. And our thought was, if we can find the thought leaders, we can more quickly reach a tipping point. So this is our social network analysis of elementary school principals of 2 programs in Hawaii. For those of you who aren't familiar with social networks, if you look at the big mess on the lower left, the people in the middle are the socially connected. The people on the outskirts are less connected. So we targeted those. And we also looked at the oral health attitude. So on the left side, the oral health attitude, we had a survey for each of them. So we graded them from lowest to highest, and connectivity as thought leader from lowest to highest. And then we intervened at the extremes with a prevention program, behavioral intervention, to see whether we could change both the return of informed consent, which is an access issue, and the improvement of health. So we've just now finishing the pilot program in the 8 schools. We're initiating scaling to 20, 40, and 80 schools. And then if successful, the U.S. has a huge number of protectorate islands or jurisdictions or colonies, depending on whose perspective across the Pacific, who have even greater needs than Hawaii. And these islands members migrate first to Hawaii and then the mainland. So huge need out there. So kind of coming back to the beginning, what we've attempted to do is integrate the best evidence with clinical judgment and local values and circumstances. We're offering programs, but people need to want to play with us, hopefully to improve health. Thank you.
Hi, everyone. I'm Patrice Pasquale, and I've been with CDHP 5 months. So when I say we, I'm not always talking about me. I'm really talking about my very talented colleagues. So I'm really pleased to be here and very grateful for the support and the friendship and collegial relations we've had with the Dental Trade Alliance Foundation. So thank you. So the Children's Dental Health Project, if you're not familiar with us, we're really working to create and advance innovative solutions to oral health. For all children, recognizing that there are some children who are at greater risk and greater suffering. We want to reduce the dental disease burden and improve access. And there's a lot of ways to go about that, and I think some of the real values of the programs that we've just heard about are really making sure that at the grass level there's ways to show progress. But we are working at different levels, at a policy level primarily. And we were started in 1997 by Dr. Burton Edelstein. He had a private pediatric dentist practice in Connecticut, and he decided to take advantage of an opportunity to be a Robert Wood Johnson Fellow and went to work for Senate Majority Leader Tom Daschle, and really started to get a good understanding of what how health policy was affecting what was happening in practices like his, and kids who weren't getting care, and why was that? We have 7 full-time staff and our budget there, and as you see, we have many funders, including DentaQuest Foundation, thank you, Ralph, and Henry Schein Cares with Steve Kess has been mentioned before, and we really appreciate all of the funders that we have. So we're doing a couple of things right now. Basically, if you look at our activity, technical assistance is a big piece of what we're doing. We're working with the CDC, with the state public health leadership and coalition building to help them exchange best practices, learn from each other. ACA implementation is the Affordable Care Act as we start to approach what's going to happen when it goes into effect in 2014. There are a lot of questions that states have. We're not necessarily funded to give them that technical assistance in an in-depth way, but we are trying to help as much as we can because people are trying to figure out the right paths to care. Dental care during pregnancy is an area that we've been working in around a lot, and we're trying to expand that work, and Medicaid and CHIP. And then the research tools, this is another strand of work that we do. We've got a prevention simulation model right now where it's looking at interventions for early childhood caries, be it varnish, be it sealants, be it toothbrushing, and trying to look at, right now we're doing New York State Medicaid kids, what would happen if these kids were following those protocols, and would you be able to see declines in caries? So that's exciting work. And water fluoridation database, which is Fluid Law, which is really trying to capture, amid all the information that is put out about fluoridation, water fluoridation, what is the case law, and what really do counties have and communities have to fall back on in terms of their own guidance. And we're just doing a survey of school-based dental programs to kind of see what the range and reach and lessons are from those. And then with policy, it's ACA, again, implementation and Medicaid and CHIP. So, why kids? I came into this not actually knowing much about kids' dental care. I had raised kids. Their teeth were pretty good. But 3 years ago, I joined a consulting company to do an editorial project for the Office of Head Start. And when that project ended, Head Start was looking for help with their dental home initiative. And they asked me to lead it, to be the contract lead, not the lead of the program. So I had a quick introduction into the world of dental caries, and all of a sudden, a lot of things started making sense. I had been a Girl Scout leader in PG County, which is a lower income relative to other incomes in Maryland, in Metro DC. And I remember a kid who, I didn't quite know what was wrong with her teeth, but I knew something was wrong. I could see the white spots. I didn't know what the source of them were. I could see some brown spots. I could see food. I knew that part wasn't good. But I just didn't know, as an educated adult, how to even look for a kid who was in trouble. So when she seemed to be having pain, when she seemed to have behavioral issues, it never occurred to me that there could be this connection. So when I was working with Head Start, that's when I really started to get an introduction. When you have a kid in a program who's not attending to learning because they are so in distress, and the teachers can't recognize it, and they don't have access to care, that's when you have a kid who, even though he's in an intervention program for early pre-K, he's not going to be able to take advantage of it. So when I heard about a kid in Kansas who had every baby tooth pulled from his mouth, a 4-year-old, trying to imagine what life is going to be like for that kid, and how did he get to that situation. And in thinking about all that, what came back to me was every parent wants the best for their kid. I truly believe that. In any work that I've done, I've seen that time and again. But there are some parents who don't have the educational background, they don't have the perspective, they haven't been brought along, like the good programs that we're talking about here, to be able to do what they can. So what CDHP does is how can we create systems so that when parents are looking for care, they can get it. So at least we can take care of that piece. So what happens to baby teeth is the single best predictor of lifelong dental disease and dysfunction. And this is a picture, which I'm sure we've all kind of seen, of these Missions of Mercy event. And here's low-income adults who likely have had problems for a lifetime. So the why now? It was shocking to me that dental caries, the bacterial infection that causes decay, is the most common childhood disease in the US. And we pulled several data sources to kind of look at this. And this is only ages 2 to 8. But if adults don't know what they're looking for, again, and if we don't see the evidence that it has eaten into a child's tooth yet, I'm not sure how, until we start confronting this, we're supposed to take action. So I really think it's important to think about the prevalence. And it is extreme. When you get to cavities at age 3, nearly 20% of kids have cavities. At age 5, nearly 50%, and that's before first grade. So we know that kids are suffering, but we also know that it's disproportionate, because children who are from lower income families are having a greater burden of the disease. And so how can we alleviate the suffering that they're facing and help them to achieve all that they can by helping them to access oral health? And this is I just include this because you all know this, but again, I think in a lot of ways we really don't know what it looks like. And so when you move from the white spots to the brown spots and then to an active infection, it gives you something to really think about why oral health matters. And then Saturday, the New York Times had this piece, which was on the Oregon's really looking at taking the lead in creating a coordinated care approach, which will include bringing in other health professionals to improve outcomes, to kind of reach the triple aim that Rick was just talking about. So here's a girl who's 4 years old. Her parents are there on the left. A program lead person is on the right, who's working with the parents, because the parents have brought the 4-year-old into the ER because the girl is complaining of tooth pain. So the face of a child suffering is often othered, and I like this picture because it helps to underscore. You don't see parents, you see parents there who are together, they're concerned, they're bringing their kid in, and they still don't know what to do. And then there's Diamante Driver. So I'm sure you all are familiar with his story, but I think it's always worth remembering him. This is a 12-year-old boy who, because his mom could not access care, he was homeless for a while, they were moving, et cetera, and frankly, instead of being worried about him, she was worried about his younger brother, who visibly had 6 rotted out teeth. She was trying to get care for that boy, missed the signs of concern for infection with Diamante until it became too late, and he died. And as a result of that, however, there were changes made. And Maryland has made great progress in terms of expanding the number of dentists participating in providing care for kids, and also making sure that kids are increasing utilization of available services. So you can have positive policy outcomes from tragedies, and this is why I always want to remember him. So where we're focused on is prevention, better health, lower cost. Again, the kind of rate of infection is something we're concerned about, but early intervention and disease management can be shown to be cost effective, and we are very interested in models. We've been trying to pull them together ourselves. We're trying to engage CMS, and we're really building on work that was made possible in part by the Dental Trade Alliance Foundation to keep on engaging policymakers to understand what the opportunities are here. So we need to get in before the disease is established. We need to understand risk. We need to involve the people who you don't think need to care about the young children, and you need to bring in nutritionists, and you need to be taking a full spectrum of responsibility. Intervene at multiple levels, we say, from tooth to policy, because there's a lot of work in between, and involve, again, community-based health promotion, education, sealants, water fluoridation, so other systems and people who really can make a difference. And coverage is essential. So dental coverage leads to greater dental utilization, and so expanded coverage means more kids are going to get care. But look at how long it has taken for us to think that the mouth is as important to overall health than the rest of the body for kids. So in 1967, EPSDT was implemented, but it took 22 years for Medicaid to get this pediatric dental benefit in. In 1997, CHIP implemented, but again, CHIP didn't have dental benefits for the first 12 years. So this is all, the grounding that had to happen to really get Congress to start paying attention, and policymakers in other areas. In 2010, we have the Affordable Care Act, and that will help to, I think the dramatic thing about the ACA is saying that dental care for pediatrics, for kids 0 to 19 is essential. I mean, it's kind of shocking that we have to say that, but it's been said now. So since it's an essential health benefit, how are we going to make it happen? And that's where we're having some challenges right now in making sure it's affordable and really well integrated. So now most children in the U.S. have a path to dental coverage. Now we have to work on improving those systems. So the Dental Child Allowance Foundation supported us in engaging in implementation of CHIP and the establishment of the ACA dental benefits, education of policymakers, advocates, the dental community, issue and policy briefs. I mean, you know, it's the messy work of policy, right? It's putting all the data together, having the right conversations, and doing the right convenings. And we've done a lot of technical assistance made possible by that funding as well. So in that period of time, we were, working with partners, and it is always with partners. As I said earlier, we are, 7 full-time people. We don't do this alone. We need everybody in. But we've been able to expand coverage to millions of kids through reauthorization of CHIP and inclusion of pediatric dental in the ACA. And CHIP is going to come up for reauthorization again, and CHIP is going to need funding again, and we need to be engaged and be there and say, in these tight budget times, can we pull back on kids in oral health? No. We have formed good relationships with federal agencies because we are a trusted broker. I mean, we gather information, we want to make it factual, and we want to be able to talk with them as they invite us about some decisions they're considering. New oral health champions in Congress. So we had some great champions at the time of the grants here. We had Olympia Snowe and Tom Harkin and, of course, Senator Bingaman and Senator Rockefeller, who have left or are leaving. And so now we're in the process of building new champions, because if we don't have champions, again, we're going to lose ground. And we've made some real, in the past couple months, we've made some good, impassioned new friends, including Senator Cardin has really taken a very strong role. And major victories for children and families with regulators and state policymakers to try to expand care there. And then moving the needle on innovation and program development. This is what we're really concerned about right now, because this is where the opportunities for prevention are. We want to move the needle. We don't want to be saying this is a good idea. We want to measure it. We want to document it. So here's to me evidence of the fact that increased opportunity creates more utilization. First, we have coverage, and I got this from Marco Vujicic, if you haven't met him, from the ADA. He's a health economist, and he just pulled the sources of dental benefit, and you can see the growth in the public insurance. Now, there's a reduction, of course, in the number of kids who are being covered by private dental insurance, and there's a small reduction in the number of kids who are uninsured, but there's a strong growth in public insurance. That says a whole number of other things about our economy and about our choices, et cetera. But what it does say is that kids, and this is kids who are using the benefit, kids have been brought in to the system in the last 10 years to get oral health care. Dental visits, we see a strong growth among kids in the 100%, under 100%, 100 to 200% of FPL. So the federal poverty level for a family of 3, it's about $19,500. So those are the families that you're looking for. So you're really seeing good growth there, again, in that same period of time. What you're seeing the opportunity for in the kids from higher income households is the ACA. That's where we can make some headway. That's where some ground to be made. And then there's a number of things that are in areas of flux because they're not fully implemented. They have the regulatory background. They have Congress's intent to be implemented, but we haven't been able to do it yet. And so we have to pay attention to all these things. I mean, for instance, surveillance. We talked about the need for data. We have a great need to be able to find out what is going on so that we can show progress, or we can challenge our assumptions and maybe make some adjustments to our own plans. The infrastructure, we want to expand to all states the opportunity for oral health programs. And dental caries disease management demonstrations is something that Congress has been interested in, but again, not funded, so that we can expand the kind of work that even Rick was talking about. Okay, I see I'm running out of time. So here's some opportunities and needs that we see. Again, I just want to use that slide on the left to show you that we really have been trying to pay attention to the kids who are suffering the most and costing the most to the system. There's an opportunity to reach those kids and get better outcomes. There's the rate of return on investment. There you go. Healthy mouth, healthy mom. Okay, thank you.